Hi, everyone. My name is Kristen Brown. I'm a cardiology fellow here at the University of Nebraska Medical Center. I'm working with Reese Adamako, resident, and Andy Goldsweg, an interventional and structural cardiology attending here at the University of Nebraska Medical Center. We'll be presenting a case today called Shunt Evaluation to Guide Patent Foramen Ovale Closure. We have no disclosures. Our case is a 51-year-old gentleman with a history of orthodeoxyplatypnia syndrome. He was found to have a large patent foramen ovale on echocardiogram and multiple small pulmonary arteriovenous malformations on CT. He was referred to us for PFO closure for severe refractory hypoxemia. His past medical history includes liver failure, status post a liver transplant, hepatopulmonary hypertension, coronary artery disease, status post PCI to the right PDA, and a deep vein thrombosis, status post 6 months of anticoagulation with warfarin. On presentation, his vitals, he was afebrile, heart rate was 73, blood pressure was 105/68. He was breathing a little bit more rapidly at 18 breaths per minute, and he was satting 85% supine and 72% sitting. Physical exam was relatively normal, except for that our patient was on 10 liters high flow and satting 88%. Here's multiple images of our non-contrast CT of his chest, denoting multiple small arteriovenous malformations denoted by the red arrows. Echocardiographic imaging showing the large PFO is seen here. The left image showing a transesophageal view of the PFO shows bidirectional flow here on color Doppler. The image on the right shows multiple cross-sections of our PFO, denoting here, you can see the length of the PFO here and the width here, which measured out to be a large PFO. On diagnostic right heart cath, you can see here the initial pressures in the right heart were mildly elevated, as well as elevated pulmonary artery pressures with normal wedge pressure. The oxygen saturations were also obtained at various levels of the heart. And you can see here clearly from the IVC to right atrium, there's about a 7% increase in oxygen saturation. You can also calculate your QPQS here. Anything greater than 1 is suggestive of a left to right shunt, and anything less than 1 is suggestive of a right to left shunt. So intraoperative transesophageal echocardiogram, seen here, was performed with several serial bubble studies. Just to orient you here, we'll use this image. LA is the left atrium. This is the intra-atrial septum, and this would be in your location of your PFO, your right atrium, and then your SVC. You can see here a Russian of our bubbles, and then a few bubbles in the left atrium within 3 beats from injection, and this is suggestive and diagnostic of a PFO. Further observation of our bubble study showed a pretty brisk amount of bubbles after 3 beats in the left atrium, strongly suggesting that there's a possible secondary shunt, most likely extracardiac, given our patient's history. So to further assess this, we engaged our PFO with a wire and engaged wiring up into our left upper pulmonary vein. We confirmed our wire location on transesophageal echocardiogram. You can see here on the top right image, you can see the wire crossing the intraatrial septum, and here's the left atrium and right atrium. We then proceeded to balloon to occlude the PFO across the intraatrial septum. And following balloon occlusion, we obtained a right atrial pressure, which was unchanged from our prior right atrial pressure. Repeat bubble study was performed with PFO occlusion to assess further a possible secondary shunt. And you can see here, even with balloon occlusion, there was a pretty brisk amount of bubbles seen in the left atrium. Given the PFO was not the principal source of shunting, no PFO closure device was placed, and our equipment was removed from our patient. So just to test our knowledge from what we've gained on this patient presentation today, oxygen saturation step up of what percentage from the IVC to right atrium is indicative of a left to right shunt? A, 7%, B, 5%, C, 3%, or D, 9%? I'll let you think about it for a second. Okay, so the answer is 7%. So just to explain this a little bit more thoroughly, just to remember, as we proceed and get closer and closer to the heart in our venous system, our oxygen consumption by our tissues increases, therefore decreasing the oxygen saturation of our blood content. If there is a hole or passageway from our left system to our right system, then there would be an increase in oxygen saturation as we go into that, closer to that area. Remember that our left heart carries oxygenated blood from the lungs to the rest of the circulation. So it makes sense that oxygen blood crossing over into deoxygenated blood would cause an increase in oxygenation on the venous side. That's why we observe for a step up. So criteria for measuring left to right shunts by oximetry, like we said before, between the SVC, IVC to right atrium, it's about 7%, and that's criteria. And every other location, right atrium to RV is 5%, RV to pulmonary artery is 5% as well. So conclusions and learning points. Extracardiac shunting should be ruled out prior to PFO closure. This can be accomplished by performing an echocardiogram with bubble study along with a right heart cath to obtain oxygen saturations at several levels to assess for a step up in oxygenation, which would suggest a left to right shunt. If a shunt does exist, the presence of an extracardiac shunt may be assessed further by repeating the bubble study while occluding the intracardiac lesion, and the degree of shunting will determine the principal source of shunting, as seen in our patient. Thank you so much for joining in today. Again, my name is Kristen Brown. I'm a cardiology fellow at the University of Nebraska Medical Center. If you have any questions or just want to reach out, you can contact me at kristen.brown@unmc.edu. And here's my Twitter account. Thank you.